Okay, so we had about 5 hours probably in between cadence procedures. So we wanted to make a little bit of a video to kind of explain, well, one, to ourselves for later purposes to update, and also for those who maybe don't understand what's going on, who don't have like such a medical background, who hasn't been really keeping up with it. So I'm gonna try my best not to make an anatomy lesson. I'm gonna try to do it all in this one take because it does get very complicated. He's a special little dude, so I'm gonna try to keep the words small and the explanations as small and quick as I possibly can, but it's gonna get complicated. So if you can't follow, whatever, just either ask questions at the end or just scroll on past. So Ashley's here to help me kind of stay on track and ask questions in case I forget something or if she doesn't understand anything. So first thing I want to do though is I want to start by going over like a normal heart, because without doing that you won't really necessarily understand kind of what makes him so different and stuff. So right here in front of me I have a picture of a normal heart that what everybody that's watching this video hopefully looks like. As you can see, we have, this is orientated in such a way that like as if you're facing the person. So this would be the right side, this would be the left side of the heart. So as you can see here, it's all abbreviated, but we have 4 chambers, 1, 2, 3, 4. The left side of the heart, as you can see, this is called the myocardium. It's very thick on this side of the heart, which is the driving force behind pumping the body, or pumping the blood from the lungs to the rest of the body. That's why this muscle layer is so thick and so developed, where you can see on the right side here it's much thinner. The reason why that is because this is a low pressure system and it only pumps blood from the right atrium, or the right atrium to the right ventricle, and then from the right ventricle to the lungs. So it's a low pressure system. It doesn't really have to fight against gravity. So it doesn't need necessarily a very strong myocardial layer. So that's a normal heart. I will refer back to that probably throughout this video just because there's so many differences between his and a normal one. So a lot of his problems are cardiac based, but the reason why they're cardiac based is really the underlying problem is actually heterotaxy, which heterotaxy is basically the flipping of all of your organs. And there's 2 different kinds. You have right-sided and left-sided. And in the way that the body works, so he has left-sided isoaneurysm, which means that everything that is mirrored of his left side. So the way that the body works is if everything is mirrored of one thing, although this one seems to be stronger or whatever, when you have 2 things that mirror each other, generally they become either underdeveloped, not developed, or not functional. And that's exactly what happened to him. So he has what they call hypoplastic left heart syndrome, which means hypoplastic means underdeveloped. Hypo means less than, plastic means development of. So he's underdeveloped left side. And then not only that, as you can see on this picture here, we have a septal, or a cardiac septum, which same thing basically in your nose, it separates the right side from the left side. And as you can tell here, there is a separation. Well, for him, he doesn't actually have that. Oh, and also, this one here, you can tell, this is where he also has something called dextrocardia, which if you can tell, this is called the apex of the heart. This is the bottom side of the heart, and it points this way. So in your chest, if you were to have it, it's here basically in the center, but the bottom is tilted this way towards your bottom right. His is dextrocardia, which means not only is it flipped, which would mean that the apex of the heart would actually be pointed over here. Well, his doesn't actually do that. It is flipped, but then it's also somewhat rotated posteriorly, which means to the back. So that also makes it complicated, especially when you're talking about EKG things. It could mess up the rhythms, the way that they look on the paper. So anyway, as far as that goes, he does not have a septum. So he only has basically 2 chambers. He has a top and a bottom. Now there is a slight myocardial layer that separates the 2, like this. However, it doesn't go from the top to the bottom, so it's basically, well, it's useless actually. So he really only has an atrium, 1 atrium and 1 ventricle. Now, I said that he has left side isoaneurysm, which means that this side is mirrored, which means it's unfunctional. The one side of his heart that is functional and it is actually wired or made correctly is the right side. But as you see over here, we said that it's a low pressure system, so it doesn't normally pump to the body. So normally it just pumps to the lungs. But in his case, we actually have to make his right side function as his whole heart. So we have to make his right side pump as if it were the left. How do we do that? Okay, this is where it gets complicated, so try to stay with me. Here we have in a normal body, we have an inferior vena cava, okay, and a superior vena cava, one that comes from the neck area, one comes from your lower body area, and this one they both dump into the right atrium, okay? Well, for him, he doesn't have that. He has actually what you call a double superior vena cava, which means he has one on the right and one on the left. Now, fun fact, I think you're messing that up by twisting it like that, but fun fact, about 30% of the population actually have this, and you won't actually know it probably until you get some kind of echo or something like that. A lot of times you'll know because there's not any complications with that. But for him, it absolutely matters, because right now, again, he doesn't have, as from birth, this is what his heart looked like from birth. He actually also has the inferior vena cava, which would normally dump into here, doesn't do that. It actually is what they call an azygous with a continuation, which it goes up and around the heart and then dumps into the right superior vena cava. Okay, that matters because what they had to do actually was, since he has no pulmonary blood supply to his lungs because of his heart anatomy called pulmonary atresia, they actually made this pulmonary, this is what you would call your pulmonary artery, connect to both of these. So now his pulmonary artery, which carries blood to the lungs, functions as the right side of his heart now, actually. So he gets all his circulation from his head and from his body everywhere through passive circulation and gravity, and this blood then goes to both lungs to become oxygenated, and then it will come back to the heart, to the right atrium, and it will be oxygenated.
How does it get back?
So basically what they had to do was create a shunt that connected this artery to his heart. So all of the blood basically pumps right back into his atrium. Now, with that, because he has, everybody has vessels that go from the liver to your heart. Those are called your hepatics. Well, that's here, and they also dump into your liver. Okay, well, now we have oxygenated blood here.
Dump into your liver.
Coming, well, the oxygenated blood that was been pumped through passive circulation and gravity goes to your lungs, comes back around, and then dumps back into the heart. That oxygen that blood is oxygenated at, anywhere from 99 to 100%. The problem with that is he's actually still getting deoxygenated blood dumping back into his atrium hasn't been yet oxygenated through the lung supply. So he's getting 99% oxygen saturated blood from his lungs, but he's getting desaturated blood from his liver. So you have unsaturated blood and saturated blood mixing together, which keeps his oxygen saturations anywhere from about 70 to 78%, which is okay right now because he's so small and his body doesn't require that much energy and that much oxygen to go about his normal day. But as he gets older, the demand will be too great for the capacity of his heart. So in order for us to increase his oxygen levels, we have to somehow figure out a way to connect his deoxygenated blood and connect it with his oxygenated blood. So the procedure that they're getting ready to do now, they've already done this part. The first two surgeries were to create a pathway from his body to his lungs for his blood to get oxygenated. So now we've extended or we've exhausted all of that surgery and everything that we can get out of that. So now we have to move to the next step, and that's what you call the Fontan surgery, which is what he's getting now. And that takes the hepatic veins, the multiple ones that he has, and it takes them away from the atrium and pushes it back up over here. And basically we're replumbing the vessels in his body to create a oxygenation system that is separate from the heart. And when that happens, we can get these hepatic veins up here. His blood, hopefully, saturation will get somewhere close to here. That's what ultimately what we want long term, because at a 70 to 75% oxygenation, you can't sustain life like that for very long, obviously, without having some major problems. So we're trying to fix that, and that will fix the oxygenation problem. However, now we have a low pressure system functioning as a high pressure system. And in layman's terms, basically, if you were to have a motor and you put it in second gear and you try to go 50 miles an hour, it will do that. The RPMs will be up quite a bit, 5,000, 6,000, 7,000 RPMs, and it will do that for a certain period of time. But eventually, it will wear out. So in the meantime, that's the option that we have. So hopefully by the time that this is just a procedure right now, we're getting ready actually for the actual cracking the chest. We're just getting imaging. So this procedure that we're doing right now, they're going in through his neck, coming in through this inferior or superior vena cava here, and they're going to take some pictures of all the little vessels, all the pathways, all the valves and everything in the heart to make sure that his numbers are good and that he's able to sustain the trauma of the surgery, essentially. But we've been getting great news so far, so we're not really concerned about that. But he's got a lot of other little things that go with it, obviously, like polysplenia is another one of the major things, because when you have left-sided isoneuritism, it mirrors everything of your left side, where your spleen is on your left side. And your spleen is responsible for multiple things, mainly blood formation and recycling of red blood cells and white blood cells. Well, he has polysplenia, which is he has multiple spleens, and that means, again, is if something is duplicated, or replicated in the body, it's virtually useless, or it doesn't function at all. And that's where we are with him. That's why we don't take him out very often when the surgeries are close, because the spleen is one of his primary functions is immune support, and he does not have a functioning spleen. He has multiple spleens. He has probably 3 or 4 or 5 multiple spleens, but none of which are functional. So his immune system is not great. So that's why we do little steps at a time to try to keep his body less stressed as we possibly can. But after this procedure, we'll have more images and more information to go off of for when his surgery is going to be scheduled. His surgeon is down here now from Baltimore, and we're just waiting. So I think I covered just about everything as far as the cardiac part of it goes. There's a lot of information, and if there's any other questions that any of you guys have, I would love to make more videos of it, just because it's hard to think of everything at one time. But there's a lot there, and we try to keep these for our records, so later on down the road we have things to go back to and see how things have changed. And not only that, it's good for him as he gets older. He can kind of understand what's going on with him. So anyway, did I forget anything?
I don't think so.
Okay. I try to keep it as basic as I possibly can. It's complicated, and if you don't have a medical background, it can be kind of hard to keep up. So if you have any questions, please put them in the comments. We're bored. We're just waiting. It gives us something to do. So if there's anything that you want to know about them, we're an open book. We try to use all this stuff for information for other people too, because without data, you can't fix anything. So
I'd like to get a picture of his heart, and so we can put it in comparison side by side. I know you did your drawing, but
yeah, I'm not a good drawer.
yeah.
All right.
That'd be good.
We'll work on that. Y'all have a wonderful day.